In adult nursing, well, a broken arm is just a broken arm.
Right, the math is pretty standard there.
Exactly. I mean, you look at the x-ray, you see the jagged white line, you set the bone, and you apply the cast. It's practically engineering.
Yeah, it's very predictable.
Uh,
But you walk into a pediatric ward, and suddenly that math is completely alive.
it really is. Like, the dosage that saves a 12-year-old could actually severely harm a 3-year-old.
Oh, absolutely. And not just because of their physical size, but because their literal biology is operating on a completely different blueprint.
Which is a huge shift. And that is exactly our mission for this deep dive today.
Right, because we were talking directly to you today, the BSN pediatric nursing student.
Yep. You're
Yeah.
transitioning from the, predictable world of adult care into a clinical landscape that is just entirely dynamic.
It really is. One of the very first lessons you learn in this
Mhm.
specialty is that pediatrics isn't just caring for little adults.
No, definitely not. You can't just take adult pathophysiology, shrink it down by 50%, and apply it to a toddler.
Exactly. So today, we are taking those foundational blueprints of pediatric growth and development that you're studying right now.
Right, we're distilling a huge stack of your nursing lecture transcripts and all those detailed slide decks to give you the ultimate clinical cheat sheet.
Because understanding these frameworks isn't just about memorizing stages to pass an exam.
No, you're learning the underlying unspoken language of your patients.
Precisely. You're learning how to translate a medical intervention into a format that their growing brains and bodies can actually process.
And we're going to cover a lot of ground. We're looking at the core principles of physical growth, growth charts, and the big three developmental frameworks from your materials.
Right, so that's Piaget's cognitive theory, Erikson's psychosocial theory, and Kohlberg's moral development stages.
And just a quick note for you listening. While Freud is often taught alongside these, we are strictly sticking to the provided source materials today.
Yeah, we're keeping it focused on those specific frameworks to really hone in on your immediate clinical application.
Okay, let's unpack this. Because before we can understand how a child thinks or, behaves, we have to understand the literal physical framework they're operating in.
Right, the hardware.
Exactly. As the lecture transcript points out, pediatrics just isn't caring for little adults.
The physical foundation of it all is so key. Growth and development are interrelated, and they're highly individualized.
Right. No two kids hit milestones at the exact same minute.
No, of course not.
Yeah.
But they do follow a fiercely predictable pattern.
There's definitely a method to the madness. And the sources outlined 3 specific patterns, right?
Yes, the 3 major patterns. First, you have cephalocaudal, which is head-to-toe
That's
development.
the toe, okay.
Then there's proximodistal, meaning center-outward development. And finally, differentiation.
Which is going from simple operations to complex functions, right?
Exactly. Simple to complex.
It actually really makes me think of building a skyscraper.
Oh, I like that.
Ah.
So,
Well, you can't just start wiring the individual rooms with electricity right away, right? First, you have to establish the central elevator shaft and the structural framing.
right. So that would be your proximodistal growth.
Exactly, the center outward stability. And then you need the overall structural top-down integrity of the building, which is your cephalocaudal, the head-to-toe growth.
That's a great analogy. You need that core and vertical stability before you can start installing the delicate, complex wiring.
Right, which is the differentiation. It completely explains why babies can hold their heavy heads up way before they have the fine motor skills to, pick up a Cheerio.
Because the core and the head have to stabilize against gravity before the nervous system gives the green light for delicate tasks.
It makes total sense when you visualize it like that. So how do we actually track this skyscraper being built?
Well, that relies heavily on specific percentiles and growth charts.
Right, like the birth to 36 months charts for girls, specifically looking at length for age and weight for age.
Yes, you plot the child's weight and length at every single visit.
Yeah.
But here is the crucial takeaway for you at the bedside.
What's the main thing to look out for?
It is never about an isolated number. A single dot on a graph doesn't tell a story. It's entirely about the trend over time.
Right, because if a kid has always hovered around the 15th percentile, they might just be naturally small.
Exactly. That's just their normal curve.
Yeah.
But if they've been steadily tracking at the 75th percentile their whole life and suddenly drop to the 15th,
Oh, wow. Yeah, that's a massive drop.
it's a huge clinical red flag. It prompts the nurse to investigate further immediately.
Because it tells you the building's construction is basically stalled out.
Right. Is there a nutritional deficit, a metabolic disorder, an underlying cardiac issue? That growth chart is your first line of diagnostic assessment.
Okay, so the hardware is installed, the physical framework is up, but, a computer doesn't really do much until you install an operating system.
No, it just sits there.
So once that physical brain grows, how does the software boot up?
And that transition to conscious thought brings us directly to Jean Piaget's 5 stages of cognitive development.
PO is huge in pediatrics.
Absolutely fundamental.
Yeah.
He mapped out how a child's mind evolves from purely reflexive actions into complex, abstract thought.
So let's run through these software updates. We start with the sensorimotor stage, right? Birth to 2 years.
Yes. The infant is progressing from basic reflexes to imitative actions.
And the sources highlight a few key milestones here, like separation, mental representations, and object permanence.
Object permanence is the big one. It's the realization that an object still exists even when it's completely out of sight.
Which is why peekaboo is basically an extreme sport for a 6-month-old.
It really is. To them, you literally vanish from the universe and then magically pop back into existence.
But once they get that object permanence, they know you're just hiding behind your hand.
Exactly. It's a massive software upgrade for their brain.
Okay, so then we hit the pre-operational stage, roughly ages 2 to 7, the toddler and early childhood phase.
Right. Language dominates here. They rely heavily on fantasy thinking, and they are very oriented to the present moment.
But there's a specific word that always gets attached to this stage in the lectures: egocentric.
Yes. Egocentrism is the hallmark of pre-operational thought.
I actually have to push back on that word a bit, though.
Oh, how come?
Well, calling a 3-year-old egocentric makes them sound like, I don't know, a selfish villain, like a tiny narcissist.
Right. It has a really negative connotation in adult language.
But really, it's a neurological limitation, right? They literally lack the brain wiring to process another viewpoint.
You've hit the nail on the head. What's fascinating here is that understanding this distinction completely changes how a pediatric nurse communicates.
Because you realize they aren't just being stubborn.
Exactly. It's a rigid cognitive boundary. You wouldn't use abstract medical jargon with a 4-year-old because that requires formal operational thinking.
Right. They can't grasp invisible concepts yet.
No. So instead, you use play. You use simple, present-oriented language. You show them the blood pressure cuff on a teddy bear first.
You translate the medicine into their current software language.
Precisely. Now, as they grow, they hit the concrete operational stage from ages 7 to 11.
And this is where the logic really kicks in, right? They master the concept of conservation.
Yes, the classic water glass experiment. They understand that pouring water into a taller, thinner glass doesn't mean there's suddenly more water.
Because they can finally process multiple variables at once.
Right. They can tell time, they can see the perspective of others, and they can solve concrete problems.
And then finally, we get to the formal operational stage, 11 years and up.
Which is the ability to think abstractly and hypothetically.
So they can evaluate the quality of their own thinking and, look beyond their current circumstances.
Exactly. So with an adolescent, you can finally explain the long-term, invisible consequences of a treatment plan.
Okay, so Piaget sets the stage for thought, the cognitive engine.
Right, the solitary software.
But a child doesn't grow up in a vacuum. They're constantly interacting with caregivers and their environment.
Which brings us to our next core framework, Erikson's psychosocial theory of development.
I love Erikson. When I look at his 5 pediatric stages, I always think of it like a video game.
A video game. Okay, break that down for me.
Well, Erikson's stages are like levels in a game. You have to face the boss battle of each stage, right?
Right, the core psychosocial crisis.
Exactly. So like toilet training in early childhood. And depending on whether you win or lose that battle, you either level up with a new skill or you take a penalty into the next level.
That is a remarkably accurate way to frame it. You carry the outcome, good or bad, into the next stage of development.
So let's look at level 1, infancy, birth to 18 months. The boss battle is trust versus mistrust.
The key event here is feeding and comfort. And the core question the infant is asking is my world safe?
And the outcome?
Well, reliability brings trust. A lack of reliable care brings mistrust.
Level 2 is early childhood, ages 2 to 3. Autonomy versus shame and doubt.
Right, and here's your toilet training boss battle. The question is, can I do things by myself?
So gaining personal control leads to autonomy, but failure or harsh criticism leads to shame.
Exactly. Then we hit preschool, ages 3 to 5, initiative versus guilt.
The key event here is exploration and play. They're asking, am I good or bad?
If they can successfully assert power over their environment, they gain initiative. But disapproval or being overly restricted results in guilt.
Then school age, 6 to 11 years old, Industry versus inferiority.
The focus shifts to school and peer activities. The question becomes, how can I be good?
So coping with those academic and social demands leads to competence or industry.
Right. And if they struggle significantly, they develop a sense of inferiority.
And the final pediatric level, adolescents ages 12 to 18. Identity versus role confusion.
The massive existential question. Who am I and where am I going?
Winning here means staying true to yourself. Losing means a weak sense of self or role confusion.
So if we connect this to family-centered care from your transcripts, this is huge for nursing students.
How does it play out on the floor?
Well, imagine an infant is hospitalized and temporarily separated from their parents.
They're going to be terrified.
Right. The nurse has to step in to answer that level 1 question. Is my world safe?
Oh, wow. So you have to respond quickly to their needs, not just to fix the medical issue, but to help secure that foundation of trust.
Exactly. You're actively treating their psychosocial development alongside their physical illness.
That is so incredibly important to remember. Okay, so we've got the cognitive logic from Piaget and the social identity from Erikson,
And when you combine those two, you inevitably arrive at how a child understands right and wrong.
which is Lawrence Kohlberg's domain, the stages of moral development, the moral compass.
Yes. Kohlberg breaks moral reasoning down into 3 main levels based on the child's evolving logic and social awareness.
First is the pre-conventional stage, right? Ages 3 to 7.
Right. And at this stage, moral reasoning is entirely based on reward and punishment.
It's all about self-interest and just avoiding getting in trouble.
Exactly. They don't have a deep internal sense of justice. They just know hitting their sibling means losing screen time.
Right. Then, around ages 8 to 13, they shift into the conventional stage.
This is where moral reasoning shifts to external ethics.
The good boy attitude and strict adherence to law and order morality.
Yes, they want to maintain relationships and societal order. They follow the rules because they are the rules.
So let me ask you this. Say you have a 10-year-old patient who follows the ward rules perfectly.
Okay, a model patient.
Right. Is it because they have some deep philosophical reverence for hospital policy?
Oh, no, not at all.
They're just in that conventional stage trying to maintain that good boy or good girl attitude.
If we connect this to the bigger picture, yes, exactly. And for you as a nursing student, knowing Kohlberg means understanding how to motivate compliance in a pediatric patient.
Right, because you can't use the same tactics for every age.
Precisely. If you need a 5-year-old to hold still, you use the pre-conventional approach.
Stickers and small rewards from the treasure chest.
Exactly. Hold still and you get a sticker. But for a 10-year-old,
You'd appeal to the conventional stage.
right, you appeal to rules, fairness, and being a helper.
Hmm.
You explain why the rule exists and praise them for cooperating with the medical team.
Finding the right key for the right lock.
Always. And just to round it out, Kohlberg's final stage is post-conventional, which is adulthood.
Where moral reasoning is based on personal ethics, principle, and the social contract.
Right, but on the pediatric floor, you'll primarily be navigating those pre-conventional and conventional waters.
Okay, this has been an incredible deep dive. Let's wrap up the mission for today.
Let's do it.
For you, the BSN student listening, pediatric nursing isn't just knowing the right medication dose.
Oh, please continue to double-check your math.
Oh, absolutely. Always check the math. But beyond that, it's triangulating a child's physical growth charts with Piaget's cognitive software.
And layering in Erikson's social quests.
Right. Plus Kohlberg's moral compass. You have to synthesize all of this to treat the whole patient.
It's complex, but it's what makes pediatrics so rewarding. And actually, I want to leave everyone with a final thought to ponder.
I love a good final thought. What is it?
Something that wasn't explicitly covered in the sources, but is crucial. What happens when these developmental tracks don't align?
Wait, really? Like they decouple?
Yes. Consider a scenario where a child's physical growth outpaces their cognitive or moral development.
Okay.
Imagine treating a physically mature adolescent, say a 15-year-old, who is developmentally delayed and still functioning in Piaget's preoperational stage.
Oh, wow. So their body is grown, but their mind is still highly present-oriented and literal.
Exactly. How does that hidden mismatch challenge your own biases?
Because your instinct would be to speak to them like a typical teenager.
Right. You'd want to use formal operational language, but that would completely fail. How does that change your approach to bedside care?
That is such a powerful question to chew on as you head into your clinicals.
It really forces you to assess the patient in front of you, not just the assumptions you bring into the room.
Definitely. Well, thank you so much for joining us on this deep dive. Keep questioning, keep exploring those blueprints, and good luck in your clinicals.